All right, well, good morning, everybody. Thanks for coming this morning. We appreciate you showing up. Go ahead and grab a cup of coffee and find a seat. I'm excited for this morning's presentation to start off these awareness and empowerment sessions. So I'm Justin Shobe, part of your Church and Society Board. Thanks for joining us this morning again. And I'm hoping to refamiliarize ourselves with issues that affect our society, both here locally and globally through these sessions. And I really truly believe that information is power. And as we re-examine the needs of the community, I hope that we can discern how to best use our resources going forward. I wanted to thank Pastor Carol Seelheimer for agreeing to allow these to take place. And I wanted to also bring attention to the graphic that we designed for this. It's posted out there on the info board. But just briefly, I wanted to take a look. And this was something that became a bit more symbolic as we started developing these. And if you look at the tree, you see reflection directly below it. And we'll make a larger version of this too. This reflection also resembles the root system, right? If we think of a tree, there's basically a reflection of that tree underneath the ground that we don't really see. And so this resembles a community to me in a way. And I believe that the population, let's talk about the population within our community here, directly results, the health of that population directly results of what's being fed into that system, right? And therefore that reflection is literally what is in the community. The tree also brings to mind the notion that we don't necessarily plant trees for ourselves. And so we plant them for our kids, our grandkids, and our great-grandkids, right? And so we nourish them, we send these into our posterity. And then the author of Genesis actually specifically refers to this in chapter 21 when Abraham plants a tamarisk tree, and he indicates that his progeny will be there trusting in the promise of God for generations to come. So in a reflection after these sessions, I hope that we can at least consider, and I hope I can consider this regularly through the week, how many trees did I plant today? How many tamarisk trees did I plant today for the people that are coming here in the next few generations? And how many things are going to live on beyond you? Also, what am I doing to feed the root system within our community that will eventually become foliage? So to start things off this week, I've invited our very own Karen Sconnard, nurse practitioner, to lead our discussion about mental health. She has been a member here for 44 years, and she was born and raised in Joplin, Montana, with 5 brothers and sisters. She started her healthcare career early in her teenage years at Liberty County Hospital with Dr. Bucher. And then she attended Columbus School of Nursing in Great Falls, worked at Liberty County Hospital again for 7 years before attending the nurse practitioner program at Montana State University. She worked again with Dr. Bucher for 7 years before moving over to Kalispell. And when she arrived here, she started at the health department with the Well Child program and family health care after that with Dr. Vranish for 17 years before eventually transitioning to mental health in 2003. She retired in 2021, but clearly she's passionately serving those around her still. I'm really excited to introduce Karen Sconnard.
Good morning. We're going to talk about mental illness today, which is a really broad, complicated kind of topic. So I'm probably just going to touch the surface, and we'll see if we have time for some questions or points of interest, whatever direction we might want to go. So I'm just going to give some general kinds of things, and then we'll spread out from there. So mental illness is a brain issue. The brain is an organ just like your kidneys, your liver, any of those other organs. And unfortunately, I don't think we treat it like an organ. We treat it like it's a dysfunction. But if your kidneys don't work right, that's a dysfunction as well. Unfortunately, for the brain, depression kinds of things, there aren't tests that you can do like blood tests, x-rays, those kinds of things to tell you that this is exactly what's going on in your brain. You can tell what's not going on, like a tumor or, other kinds of neurological things, but you can't identify that this is depression or anxiety by doing any of those kinds of tests. So if someone presents to the clinic with these symptoms, they may have all of these tests done to rule out other things, because a lot of times the symptoms, are parallel to other disease processes. So sometimes those tests have to be done. Blood test doesn't give you any indication about mental illness. It tells you what you don't have. A lot of times physical illnesses are comorbid with mental illness. So you have to identify that and treat it in order to have the whole process be stabilized. So with that said, we think about things like neurotransmitters in the brain. You've heard of serotonin, and serotonin is an enzyme that regulates your mood process. There's also norepinephrine, which is another enzyme. If these are out of balance, so to speak, that's when emotional instability is starting to happen. And there's no way to identify a serotonin level. When people will say, I'm going to have my serotonin level checked, well, that really isn't very accurate into, determining about mental illness. There's a whole lot of other things that would have to go along with it. So you have to look at it kind of as it's a process of elimination when you're looking at some of the symptoms for the mental illness kind of thing, because they can look a lot like the other things. I just want to do a few statistics. To me, I don't like statistics, they're kind of boring, but I think it's important to know about this. So in Montana, we probably have about 1 million people. So 44,000 people in Montana, so to speak, are affected by mental illness. And I'm thinking about serious mental illness, and I'll talk a little bit about that difference. That means also that half of those people are not getting any help for their mental illness for a variety of reasons. Some of it's financial, some of it's geographic, some of it's their own personal choice. Some people don't want to be identified as having a mental illness, so they choose not to get help. Montana right now is number 3 of the states. Wyoming's number 1, Alaska's number 2, but Montana's been number 1 off and on. And I'll talk a little bit about suicide and with some different numbers here in a minute. In the United States, suicide numbers are like 13.5 per 100,000. And again, that number changes. Apparently, that's an increase of about 30% of suicides over the last 10 years. So that's pretty significant, I would say, that's been happening. Whether or not it's just more identified as a cause of death, I don't know that. I would say probably it's an increase in the amount of people that are actually committing suicide. Interesting fact is 75% of suicides occur in their home. So that's kind of an interesting. Access to care is a lot of times for Montana especially, and maybe these other rural communities, like I would think about like Wyoming, Alaska, some of these smaller or diverse communities. There's no way for them to get to a facility that has mental health services, and mental health services aren't a part of normal health care. So they may have a small clinic in their town, but they don't have any access to the mental health care. And for someone who has a mental illness to travel a long ways to get care, it's not something they either have the energy to do or they don't have the resources. So they just go without care and get along in life best they can. And that's the products that we a lot of times see. Interesting fact, the less amount of sunshine that you have, the more likely you are to have difficulty with depression and or anxiety. Same with vitamin D level. So a vitamin D level is important to kind of keep in the back of your mind, like what's happening with my vitamin D level. And I think medical providers are actually checking vitamin D levels a lot more routinely than was happening in the past. And for me personally, I've been interested to see how many kids have a really low vitamin D level. Whether it's because they don't play outside, we wear a lot of sunscreen, I'm not sure. but vitamin D is an important factor in keeping that brain chemistry, at a level kind of thing. The effects of drugs and alcohol we don't even know how to explain all of that. So whether or not that has had a big impact in the increase of suicides over the years, very likely. People who are typically struggling with mental illness, using drugs, alcohol, another form of substance, tend to either, if they are taking medication, not take their medication, but those substances also interfere with the benefits of their medication. Nicotine is the basic one that doesn't let medication like that be very effective. So people with depression, anxiety, just kind of basic, are taking an antidepressant, they're probably not getting a very good benefit out of that just because of how the nicotine interferes with how it helps you. So those are factors that we have to keep thinking about. And in my practice, people that had serious mental illness, every one of them smoked tons of cigarettes every day. You didn't even know what else they were doing, but the cigarette thing was a major. And I'm thinking, here we are just, pumping all this medicine into them, but we can't get them to stop smoking, which might cut down the amount of medicine they'd need. I don't know. So, but that's kind of one of the researches that have been looked at, just as far as nicotine goes. And it probably happens with other medications as well, but definitely with mental health medications. In Montana, suicides are, we're not number one in suicides in the nation, but Flathead County is number one in the state of Montana. And firearms over the course, the whole United States is the major cause of suicide. That's the major way that suicide is happening, and it's 63% by firearms. And like I said, most suicides happen in a home. Otherwise, like overdose is an attempt that's used probably more than firearms, but the lethal part of an overdose isn't happening as much. A lot of people take too many pills, but there's time to get them, to care so that an intervention can happen so that, it's not resulting in a death. But the use of pills or something like that, ingestion of something is probably higher than firearms, but the result doesn't end up in death. Hanging is another high percentage of, how suicide happens. Another interesting point, men over 75 have a very high rate of suicide. I thought that was really interesting, but I think it's because by that age, for a man, they've given up their careers, maybe they've struggled with some health issues, maybe marital issues, things that are a lot more stressful to them by the time they've gotten older, and they feel very hopeless. They certainly aren't going to access care because that's not something that you would do as a man. So apparently they're showing that the suicide rate in men of that age has gotten to be a lot higher. I want to go back to access of care. I was thinking as I was doing this, when I was first in nursing, I don't think I even knew what the word suicide meant. And I certainly didn't know of anyone for a long time that had committed suicide. So I don't think it was because it wasn't happening, but nobody ever talked about it. So that's the interesting part. Now we are at least talking about it and trying to have some identification with it. How many of you have ever gone to a baby shower or some kind of an event and the person you're sitting by talking about getting their gallbladder taken out, they've just had COVID, they've just Does anybody talk about how depressed they've been, how anxious they are? We don't talk about those things. And it's kind of interesting because our brain is no different than any of our other organs, but we're not going to talk about those things as a way of even getting support from other people. So hopefully, as we become better educated and have a better support system, that kind of communication, you know, not that you have to sit around the coffee table talking about those things, but you should be able to feel comfortable to talk to someone about those kinds of things, because that's the only way you can access care. The other thing I think that's difficult with the care part is when you go to the clinic for a medical kind of thing, usually it can be identified very quickly, maybe a few tests, maybe one other appointment, and there's an answer and a treatment plan. With mental illness, developing a relationship with the person that you're going to take care of doesn't happen on the first visit, even though you might spend an hour talking with them. So you're not able to actually develop a treatment plan and have, okay, this is what we're going to do so that this gets better by next week. That's not going to happen. So you have to build some kind of trust with that person, number one, so they'll come back, and then you can keep working on a treatment plan and determine what avenue is going to go from there. It's rare that a person would come for an evaluation for mental illness, whether it's depression, anxiety, schizophrenia, bipolar disorder, ADD, any of those things, that maybe medication wouldn't be one of the treatment options, but it isn't necessarily something that can happen on a first visit. So if somebody comes, they're feeling extremely desperate, and they don't walk out of your office with a prescription that's going to make them feel better in 2 days, like an antibiotic does for strep throat, they might not come back again unless you've really developed some kind of a rapport and relationship, and you can encourage them during that process. Because you can be sure by the time they've come to your office, they've explored a lot of other options and they're feeling pretty desperate. So you need to be able to reassure them that this isn't going to get worse, so we can make this get better, hopefully. It was interesting, when I first decided to go into mental health work, one of my colleagues said to me, "What's it going to be like to take care of people who never get better?" I was like, I wonder what they mean by that. And I was like, that's not true. They do get better. But sometimes the markers that you look for is in 2 weeks, when somebody comes back to see you, they've combed their hair, they've taken a shower, little things like that. It's not like magically the depression or the anxiety or those other symptoms have gone away, but they've been able to get some sleep. They can look in the mirror and say, I need to comb my hair today, or they feel like taking a shower. To me, that's progress, and that's the step for them. They are getting better, and they do get better. So that was encouraged. I was like, they do get better. I can tell you that. So kids, the percentage of kids that struggle with mental illness, and I'm talking about ages like 5 to 16 maybe, is like 1 in 5. And that is a lot. And if you think about, if you're a teacher, what that means, because you're talking about kids that have oppositional behaviors, attention behaviors, anxiety. Kids have depression. And a lot of times in kids, those symptoms come out with anger. Like, those kids are so angry, and they're so impulsive and explosive, and they just don't know how to manage that. And how many times have you heard somebody say, when a child or an adult has kind of an outburst or an inappropriate behavior, and the reference is, oh, they have bipolar? Well, that's so wrong, because that's not what bipolar diagnosis is. It's a whole different set of how symptoms go in cycles. And maybe one of the symptoms of a bipolar disorder is irritability or, anger, but it certainly does not identify what bipolar diagnosis is. So I get kind of like the chills when I hear people just refer to, oh, they must have bipolar. Like, no, I don't think so. Let's evaluate that a little more. So kids have a whole different presentation of those symptoms. And if a child, because you can have children with bipolar disorder, but it's probably not something that can be diagnosed when they're young. It's going to evolve to, look different as they get a little bit older. Same with teenagers. You struggle with the hormone kinds of things and what happens with all of that as their symptoms, as their brain chemistry is changing. So you might have to treat symptoms along the way, but you may not have a definite diagnosis. It's not uncommon for a child, an adolescent, or an adult to have more than one kind of mental illness. ADHD can go along with anxiety and depression, can go along with bipolar. So you have two separate things that need two different kinds of a treatment approach. So you have to be able to sort out which symptom goes with which, because the treatment is going to be different. I always, as I was doing this work, thought this is like being a detective, because you have to have lots of questions and actually you have permission to ask all these questions because they just are able to give you that information. So it's pretty fascinating actually to get all these stories. But and when I've thought, okay, I've heard it all. I can't believe I'd ever hear anything different. Next person, it's all different and it's a new story. And you get to start all over again. So it gets pretty fascinating in that way. The other thing is that in jails, incarceration, 2 out of 5 people have serious mental illness. That's a pretty high percentage. So when we think about our homeless population, I would guess, and I think about this as I'm, driving around town or doing little things and I see a homeless person and I think, I wonder what their mental illness is, because I would guess almost all of them have some kind of mental illness. If they don't have schizophrenia or some kind of a disordered thought process, they certainly must have depression or anxiety. And anxiety can be extremely debilitating for a lot of people. And maybe that's why some people are homeless. They have way too much anxiety to even spend the night in a homeless shelter. That happens. They can't be around people, the noise, maybe they have PTSD, which brings up other things. So I think that all of those things play a part in what's going on with our homeless population, and we have to be paying attention. If you see somebody kind of walking around with their bag, staying on a street corner, they're talking to themselves or they're pointing and talking, most likely that person has schizophrenia, which is considered to be a thought disorder. To them, they are literally hearing voices. They hear people talking to them. They're seeing things that you and I don't see, and they're not imagining it. It's very, very real to them. And if you sit down and talk to that person, you can't tell them, well, no, there aren't 4 horses standing on that corner, because to them there is. And so until their brain chemistry gets kind of redirected back into more of a normal pattern, then that's not going to change for them. The other interesting thing about medication for these people is not only the nicotine, maybe how it decreases the effectiveness, but also they might start medication because somebody has encouraged them to get help. So they start their medication, they feel better, their brain feels better, then they stop their medicine. So it goes right back to where they were before. So each time that happens, it takes it's like 50% less effectiveness of those medications. So the second time around takes a little more medication, and the third time around takes a lot more medication. Pretty soon, medication isn't going to be very effective, for what they need. Maybe you can get them down a little bit with some of their symptoms, but you're not going to get to a place where they can function like they would if they would have maybe stayed on medication. So all of these things play a part in what we see in a community, and we see it in our community all the time, about why the mental illness piece seems to be kind of out of control. But the other piece is we don't have access to care for people with mental health. Waiting times for appointments can be many months. We don't really even have, we maybe have one mental health center now. Well, Western Montana Mental Health Center has very limited resources again. Sunburst Mental Health Center has limited resources. And it just goes down to finances. Because I worked at Sunburst Mental Health Center for quite a while. There were months when we could barely keep the lights on because the reimbursement for payment is so low that it doesn't cover even the expenses of running your building. And you can be sure that the people that work there make very little money. Those social workers, those therapists, they work very, very hard and they get paid very little. So, they're not going to stay. It's hard work. And if they can get a job across the street and make more money, that's what they're going to do. Some of them are very, very passionate about what they do. And we're lucky for that group of people that, they'll just do it for whatever they can do. But everybody has to pay their bills and I think, so the reimbursement comes mostly through our Medicaid program and also for Medicare. So typically that reimbursement rate is much lower than an insurance company. And we have very few people that have private insurance that go to a mental health center. So, I don't know. The bottom line is we just keep talking to legislatures. We try to find out why there's such a limited amount of financial access. There's just, I don't understand why that happens, but it does, and that's what our challenge is. It's costly to have a mental health program because you don't just have a medical provider to write a prescription. That's the minimal piece of it. The therapy piece is huge. The social worker who does, community work with these people, making sure they know how to buy groceries, how do they pay their bills, how do they clean their house. All of these things have to be a whole part of that treatment plan. So for one person, it could easily take 3 people to take care of them. Whereas when you go to the doctor's office, you have your doctor, and that's kind of, or you might change and have another doctor, but you're not going to have maybe 3 or 4 at a time. Sometimes that happens, but with someone with serious mental illness, for them to get the adequate care, it's going to take at least that many people, plus any other support person you can get, because maybe they don't have transportation. They certainly don't always get out of bed in time to get to their appointments. So somebody has to be thinking about all of these logistics for these people with serious mental illness in order for their care to be something that's, going to be optimal. They just can't do it on their own. The interesting thing is almost all people with mental illness, and maybe this is too big of a generalize, they always have a pet, like a dog or cat or something. I think that's really good, because there are many times when I've asked somebody who has said, I really feel suicidal, and I'll say, well, what's kept you from being, carrying this out? And they'll say, I'm not going to leave my dog, or my cat wouldn't have anybody to take care of them, or sometimes it's a bird. But those animals are really an important source for those people with mental illness. And sometimes you get kind of frustrated. You see that person walking down the street, all they have is a backpack or something, and they're smoking cigarettes and carrying their dog. And you're like, why do they have a dog? Are they taking care of that dog? They'll take care of their dog before they take care of themselves. So it's a pretty important connection for them to have. So I guess you always have to think about that. So we have one state hospital in Montana, Warm Springs. I think every state has some kind of a generalized institution program like that. And that is a place where people with extreme serious mental illness are sent for their treatment. And as you read the paper the last several months, our program has kind of gotten in a really bad place. And from what I could find in information that was out there, it's, part of it's a financial, there's no money for resources that they need to take care of these people who are so mentally ill, because sometimes it's one-on-one and they have over 200 patients. So there's no way they have near enough employees. And it's very, very hard work. So between not having a good resource, and you have to think about, I don't know what year the buildings were made in Warm Springs, but it was like many years ago, maybe over 100 years ago or 150 years ago or something. So there's old structures. They were old when I was there a long, long time ago. I was like, oh my gosh. And when I was in Warm Springs as a student, there were, I don't know how many buildings were full up to capacity, and people were just, the treatment plan was like major medication. Everybody was just like, nobody could. One of our assigns was to do a journaling visit with a patient every day and journal. And I was like, how can I journal when I can't get this person to talk? Well, they couldn't talk because they had too much medicine, but that's the way they took care of people. And so that part has transitioned. That doesn't happen. But the facility isn't a very good resource at this point. So hopefully somebody's working on that. And I guess as we are in our communities, the things we do are stay in touch with people who make those decisions, whatever way that is, writing letters or phone calls or, personal interactions with them. I think it's important to understand what do those people know and what do they think about mental illness? And then what are they going to take back to their group? And what does peer pressure do to influence how they make decisions? Because maybe they say one thing to us, but that's not what happens when they get in their group of other people who are talking about those things. So I think that's important. I always thought if they could just visit one of these places for a day, not even a day, maybe that would make a difference, but I don't know that it would. So different things that would help with mental illness, maybe, I don't know if it's as a prevention, we're not going to prevent it. We're going to try to treat it and minimize it. Definitely drugs, alcohol, nicotine in a way. Trauma is a huge impact on the effects of mental illness. Abuse, neglect, all of these things affect these mental health things. So you think about kids in school, the bullying that might go on, and how it affects kids with anxiety, or if they're feeling pretty unsure about themselves. Sometimes that leads them down a path. There's a certain component of genetics that goes with mental illness. So if someone is genetically predisposed to a mental illness, depression, anxiety, bipolar disorder, schizophrenia, and they have a lot of these other things on top of it, they're going to be more likely to develop those symptoms maybe sooner. So without a support system, that's going to happen. Simple little things day to day: sleep, diet, exercise. I don't know if you read the paper this morning, but there was a thing in there, 7 ways to fight depression. Exercise, limit social media, find a mantra, sleep, talk to family and friends, practice gratitude, and do something creative. Those are pretty simple things. But if somebody's in the middle of feeling extremely depressed or extremely anxious, or their thoughts are pretty disorganized, when you sit down and you tell them those things, it doesn't mean anything. And they can't even, like, what do you mean you want me to eat different? You know, they can't quite put that together. What do you mean I have to get out of bed? What do you mean I have to sleep? What do you mean I have to turn off my iPad or my telephone, or, you know, that's my lifeline. You know, they just can't comprehend those kinds of things. So we have to get them to a stable place before you can really have them talk about those things. And as a community, I think we are doing the things that are recommended, providing safe places for these people. You know, we now have our warming center, which is really good. Samaritan House is excellent. You know, those places go to capacity though. So, you know, we just have to keep doing that. Be kind to people, just in general. We have to try to be kind to the person that's standing on the street, you know, saying foul things. I don't know if you've been on the bypass on your bike lately or gone for a walk, but it's not uncommon for a homeless person to be sleeping under the, you know, the trellises, and it's kind of scary. And when they're talking to you or pointing things at you, it's hard to say, I want to really show them some kindness, but maybe that's all they need is somebody to say good morning to them, or, you know, something. But out of our own fear, we kind of don't react the way maybe we should. I think our law enforcement program here in Kalispell is definitely expanding in the right direction. They have social workers now that are working with them on mental health calls, and, you know, so the ideas are there, and we just have to hope that those things can expand so that we can meet the need as it keeps growing. So, but I'm going to open it up for questions or comments. If anybody has any. Justin.
I was curious if you could talk about what led you to transition to mental health work.
Oh.
And if, besides money, what would attract, how could we encourage young people
to go into that? When I did family practice for a long time, and I always was kind of like, if I was taking care of someone who either had what I thought was depression or anxiety, I was always like excited to be able to figure out a plan for them. I don't know why, but, and the way they would put the charts up, like when we did urgent care, and maybe it would say, maybe the person came in and said, I'm depressed. So the nurse would write depressed on the chart. So if I was standing by my colleague and we're looking at it and it said depressed, and they're like, I'll do it. I don't know why. I have some family, you know, some personal things that maybe sparked my interest. I don't know. But I just have always been kind of intrigued by what's going on in your brain and all of these. And like I said, you're like a detective, because you get to ask all these questions and find out all these stories. And it's pretty fascinating. And so I think that compassion has to be maybe what spurs young people. I mean, a certain kind of compassion, I don't know. It's hard work, but it all is hard work. So I guess just education and compassion is how you would hopefully direct a young person into wanting to be taking these fields. So, yeah. That's all I have. Peg?
Good morning. A very, very small piece of this huge puzzle is just statistics.
Mhm.
And statistics equate to dollars,
Mhm.
right? Years ago, I don't know what year it was, during my career, so it's probably been 10, 15 years ago. The district courts, which is the judiciary, keeps track of mental health cases.
Mhm.
So your most serious mental health cases come to the district court. Then there's commitments, temporary commitments to Warm Springs from the district courts, right? This is how people get to Warm Springs, is through the court
Yeah.
system. And years ago, they changed, the district court council for the state of Montana changed the way that we're keeping track of statistics
Mm.
for mental health cases in the courts, because instead of opening a new case, you know, for Peg Allison because she's having trouble, and then maybe she goes to Warm Springs, and then maybe she's fine for months and or years. If she comes back to the court system, that same case is used for the new petition. So we have no new statistic.
Yeah.
But yet it's
New-
another
yeah.
commitment, and
Yeah.
so it's another issue, it just happens to be the same person.
Yeah.
So like, for instance, our mental health statistics this year are really low.
Yeah, I noticed that.
I mean, they're half of what they
Yeah.
were for last year.
Yeah.
And I looked at that the other day and I thought, that's interesting. It's a good thing. We
Yeah.
have very few new people coming through the system. But how many
Repeats.
repeats and recidivism do we have
Right.
going on in the mental health world that
Yep.
we don't even know about?
Right.
At least not in the judiciary.
Right.
And this statistics that come out of the courts is often what the legislature looks at.
Yeah.
And hospitals, I'm sure, keep their statistics, and so I know Warm Springs has their statistics.
Yeah.
Do they have a direct line to the legislature the way the court system?
I would hope so.
You know,
But
right?
yeah.
I would hope so too.
Yeah.
But it's just another piece of that puzzle.
Yeah.
And you really can't tell through the
Yeah.
judiciary how many mental health cases we really have
Yeah.
going through the system in every county, every year.
Yeah.
It's an interesting point.
Well, and I talked to different people that are, in the hospital here, and how many people are admitted for, alcohol, like overdose of alcohol, overdose of drugs, all these kinds of things. They're basically treated for that and released immediately, but there's no exploration into what the underlying mental health piece is for that person. And almost all the time, there's some kind of a mental health piece that's related to a chemical use. Anxiety is a big one. It's easy to take a substance to make your anxiety feel better. So that piece is totally missing. We have a very, very small psychiatric unit considering the number of people that need to have the care. We have no inpatient treatment for chemical dependency. And to get somebody into an inpatient treatment program in Montana is weeks. Well, you know what happens? Somebody says, today I'm ready to go to a treatment program, but they can't get in for weeks. By the time you get them a bed, can't even find them maybe, or they've changed their mind. So that whole piece for care is missing, because then the mental health piece goes unaddressed. And like I said, every time a person has a psychiatric setback, so to speak, it damages those neurotransmitters in their brain, and they're not able to get back up to that level again. So it's just a constant barrage of deterioration in a way, because you can never get it back to the place where it was before. That's why you want to prevent all of these relapses, so to speak. Hopefully by people taking their medication, staying in a treatment plan, avoiding those kinds of things as much as possible. And that's the other piece that we're missing. And some of the times people decide, I'm not better in this very short period of time, so why should I keep doing this? So they don't. Side effects of the medicine a lot of times are not great. Side effects can be less than what the disease is, but you can't convince somebody, and I'm no different. I'm not going to take a medicine that makes me feel awful, but I can manage this piece of it. So there's just all of those things that come as a part of a huge education piece that needs to come from providers, support people, families. You need to involve all their families. Just that whole big piece. It takes a lot of people. So, Jeannie?
Karen, can you speak to school-based mental health a little bit?
Mhm.
And when kids age out of that, what happens?
Very good question, Jeannie, because Jeannie wanted to know about, she mentioned the school-based mental health program, which has been instituted for kids that are in school now so that they have an avenue of support, some diagnosis, referrals, family interventions can happen through that. And when the kids graduate from high school, there's, what happens to them? Nothing. Unless they have a very good rapport and they have felt, extremely connected, and they still need to have some ongoing help, they may transition on their own, because now at age 18, they're responsible for their own care. So basically, they're lost. So that's a piece that's not good, because at that point, they're still having all these hormonal changes. They're really experimenting with chemicals. Social media is a huge impact. And those are negative things. They trying to figure out what they want to do, and, lots of things. So it's a bad time for them to lose that support. So, yeah. Thank you.
All right, thanks everybody. Join us again next week. Hillary Shaw from the Abbey Shelter will be joining us.